you, Professor Naha. Yeah, I'm Dr. Wong Kuan. I'm currently the head of the division of the respiratory unit of our medical department, UMMC. So it's my pleasure to become the moderator for the second session. So I'll be moderating this session whereby we'll be talking about difficult to treat asthma. Okay. So difficult to treat asthma is something that is what you call actively debating whether most of how many of our patients is actually having a severe asthma, how many of them is actually having difficult to treat asthma. So and how to diagnose this kind of conditions. So today we're going to talk about this situation whereby my fellow respiratory Dr. Loh. So she'll be talking on this topic. She's currently the clinical specialist and the medical lecturer of the Division of Respiratory Medicine. And she has obtained her internal medicine qualification in 2016 and currently a fellow in our respiratory medicine. And she's also actively managing conditions such as airway disorder. So asthma is her passion, and she has been actively involved in the difficult to treat asthma clinic. And she would be the best person to tell us on what is happening in difficult to treat asthma clinic. So without further ado, I would like to invite Dr. Loh to present her topic on difficult to treat asthma. Before that, I would also like to ask the audience, the participant to ask any questions. You can actually drop your questions in the Q&A box. Dr. Loh, the floor is yours.
Thank you very much, Dr. Wong, for the kind introduction. A very good morning to everyone, and thank you for spending your morning to attend this talk. I'm Dr. Loh from the Division of Respiratory Medicine, Department of Medicine, University Malaya. So today I'll be spending a little bit of time talking about a topic which is very common, which is difficult to treat the asthma. So asthma, as we know, is a very common disease affecting patients of all age. And I'm sure some of us here are being asthmatic or have any family or friends being diagnosed as asthma. It's estimated the global prevalence of asthma ranging from 1% to 18%. And up to date, the more than 300 billion individual is affected by asthma worldwide. So what about our local data? This is the number of patients attending our UMMC chest clinic from January to May 2020. And actually 26% of these patients are asthmatic. So means that the asthma is actually a major disease from the respiratory diseases point of view. Many of these asthma patients still suffer from persistent symptoms. This is a beautiful study looking at patients suffering from asthma in Asian Pacific. And if you can keep your attention to the orange bar, which represents Malaysia, 22 to 24% of asthmatic patients still suffer from symptoms every day and every night. These patients also exacerbate. This is the data looking at admissions to our respiratory ward from January to June last year. And acute exacerbation of bronchial asthma actually counts 16.7% of our total admission, which is the second highest after respiratory infection like community-acquired pneumonia. Uncontrolled asthma exerts significant economic and health burden to our society. So this is a study done in the United States, and the direct costs estimated caused by uncontrolled asthma exceeds 15 billion in 2019, and it has been projected to continue to increase in the next 20 years. So these direct costs includes healthcare provider visits like GPs, emergency visits, hospitalizations, and all the medications needed to treat asthma. What about the indirect cause? So these studies have shown that a good significant number of asthmatic patients had missed work or school days due to their asthma. And at the best, they can only perform up to 70+% level of productivity. And if they have asthma attacks, the level of productivity will reduce further. In fact, asthma control is a matter of perspective. Despite having daily symptoms, loss of work productivity and exacerbation, most of these patients, in fact, more than 50%, think that they are well controlled. In fact, if we get all these patients to fill up a proper questionnaire on asthma control, only 6% actually categorize as properly well controlled, whereas the rest, the huge percentage, are either partly controlled or uncontrolled. So what about asthma control in our own patients? Most of these patients actually at the higher end of treatment, which is step 4 and step 5. And actually, 52.3% have an asthma control test score less than 20, which puts them into the category of partly controlled or uncontrolled. So this is the latest global initiative for asthma, or GINA 2021 proposed guideline to treat asthma. So it's a stepwise approach based on patient's level of control, and we can step up the treatment to optimize the patient's symptoms and exacerbation. So the higher the steps of asthma treatment, the more medication we need or use to control their symptom and to reduce exacerbation. So I'm sure all of you have heard different terms when it comes to uncontrolled asthma. Patient with lots of symptoms frequently visits ED, admitted to the ward. So people label them as controlled asthma, difficult to treat asthma, or severe asthma. But are all these terms the same? Or do they carry their own identity on their own? So let me do some clarifications of the definition. So uncontrolled asthma is defined as poor symptom control and frequent exacerbation, which defined as exacerbation needing oral corticosteroid more than 2 courses a year, or a serious exacerbation requiring hospitalization 1 or more episodes per year. What about difficult to treat asthma, which is our topic for today? Difficult to treat asthma is defined as uncontrolled asthma despite GINA step 4 or 5 treatment. And severe asthma, actually it's a subgroup of difficult to treat asthma, but with the account of good adherence and maximum optimized therapy, and also treatment of other contributing factors. So there are a few other terms that I'm sure all of us have heard before as well, which is mild, moderate, and severe asthma. So mild asthma just literally means patients are well controlled with minimal treatment like step 1 or step 2, while moderate asthma needs a little bit higher, step 3 or step 4, and severe asthma will need the highest step, which is step 5. So there's a fine line and interaction between these two terms, asthma control and asthma severity. Control, it really means the extent to which the manifestation of asthma, which is symptoms, risk of exacerbation, and persistent airflow limitation, which can be observed in your patients, or had been reduced by the treatment. So that is the level of control of your asthma patient. However, severity literally means the level of treatment needing to achieve the control. So what are the types of medication or the steps that need to achieve the so-called control of symptoms and exacerbation? But that has to be taken account after we manage all other concomitant factors. So after we tease out or manage all these patients, in fact, only very few has severe asthma. A very nice study done in the Dutch population And they found only 24% out of all asthmatics are in the step 4 to step 5 treatment. And out of this 24%, only 17% has difficult to treat asthma, meaning their symptoms are still uncontrolled. And after we manage all other concomitant factors, for example, adherence and inhaler technique, only 3.7% are truly severe. So in our clinic, out of 572 patients who attend our asthma clinic, we have found that most patients are in step 4 and step 5 of treatment. So meaning that a huge majority of patients are in the difficult to treat asthma. And more than half is actually at the highest end of treatment, which is step 5. And if we remember the GINA guideline, in step 4 and step 5, patient will be either on medium to high dose ICS LABA, and if the symptoms are uncontrolled, there is option of add-on of LAMA or other high-end biologics injection like anti-IgE, anti-IL-5, and anti-IL-4R. But in our clinic, majority of them are on triple therapy, which is inhaled corticosteroid, long-acting beta agonist, and long-acting muscarinic antagonist. And only a small proportion of them need regular oral corticosteroid, and a smaller proportion are actually on biologics injection. So this so-called difficult to treat asthma, there are a lot of things that we need to consider before we finally label someone as severe asthma. So these are a list of factors that we need to consider, which include adherence, inhaler technique, other comorbidities that come together with asthma, their continuous trigger exposure, and other concomitant diagnoses on top of asthma or pathologies that we need to recognize. But at the end of the day, I think we still need to take a step back and reconsider the diagnosis whether this is really truly asthma. It sounds like a very simple question to ask whether this is asthma. So this is a very interesting study done on 613 subjects. When these patients are initially being labeled as being asthma, and what Aaron et al. In their team are doing, they're trying to revise the diagnosis using a few assessment steps. First, these subjects undergo spirometry with pre- and post-bronchodilator testing to test the reversibility airflow obstruction, which is a hallmark in asthma. And then they will proceed with broncho hyperresponsiveness tests, for example, Methacholine challenge test. And if these two are negative, they will proceed with tapering down the dose of asthma treatment and see if the symptoms worsen after the reduction of treatment. And if all these three steps are negative, patient will be sent to a pulmonologist for refining of diagnosis. And to our surprise, out of 600 subjects, a third of them has actually asthma being ruled out. So this creates a question when we see a patient, when we say someone is having an asthma, is it truly asthma? So this table actually shows that the hallmark symptoms of asthma like dyspnea, wheeze, chest tightness, and cough actually present in patients who does not have asthma as well. So having said, to revise the diagnosis of asthma is actually not that easy. And for those patients who's got asthma ruled out, there's this huge long list of actual diagnoses of this patient is actually suffering from. So in fact, all these symptoms are non-specific and all these other diseases mimic each other, making the diagnosis of asthma rather difficult. Second thing is about adherence. This is a nice study just published last year by our Malaysian colleague looking at the adherence of asthma patients to their medication. And surprisingly, half of them actually admitted forgetting to take their medication at any point of time, and 42% will take less medication at any time, and about a third of them actually stop taking their medications when they feel better. And this is another study correlates the level of control of asthma to their adherence. And it's not surprising, mainly the partly controlled and uncontrolled patients will have a lot of adherence issue by forgetting their medication or stop taking their medication when they feel better. This is just a study looking at a biologic injection, which is dupilumab in severe asthma. But I'm showing this slide not to illustrate how effective dupilumab in treating severe asthma, but just to point out, in this group of severe asthma receiving placebo, still managed to reduce their oral corticosteroid dose to 50% just by being in the clinical trial. So what is this telling us? So it means that when patient is participating in a clinical trial, they're under a very controlled environment with good adherence and inhaler technique. And all this simple maneuver managed to reduce the need of high-end treatment to control their asthma. So to make things more complicated, there are many types of inhaler devices with different combination of molecules in them. So I would not blame patients for being confused, because I think the doctors and other healthcare professionals are confused too. So this is a study done in 2017, looking at the number of patients being assessed of the inhaler technique, and this is a systematic review. And actually, a good proportion, 28% of them, will at least conduct at least one critical error in the inhaler technique, leading to the inhaler medication being less effective. And if you can see, inhaler technique is actually not that simple. Just for a normal PMDI that has been in the market for decades, there's actually a lot of steps where critical error can happen. And if you think that this critical error can be fixed with an aero chamber, maybe you're wrong. By adding an aero chamber or spacer creates more space for critical errors. And don't forget about other inhalers, like dry powder inhaler, your AccuHaler, and also your Tuberhaler. So patients would be confused with all these different steps and different inhaler technique of different devices. And to make things worse, hey doc, I have a few inhalers now. Now which one is which? Patients are confused, and so are we. So this is a very old study, but illustrates very well on how nurses and doctors themselves are not even perfect when it comes to inhaler technique. In the PMDI, most of them actually perform quite badly from step 7 to 11, which is really the inhaling process and the breath holding process while using an inhaler. And things get worse if you give them a different inhaler like the dry powder inhaler, Tuberhaler. And I think it's no-brainer. A poor inhaler technique leads to worse asthma control. So this is a study looking at patients with asthma coming into the clinical practice for 3 visits, and every visit they will reinforce the inhaler technique. And as you can see in this table, as patients progress from visit 1 to visit 3, their number of steps being correct has increased significantly. And as their inhaler technique gets better, the number of patients who are fully controlled also increase, with a concomitant reduction of patients with uncontrolled asthma. So other factors that we need to fix in asthma patients is other comorbidities that come together with asthma. The very common one is allergic rhinitis. So a combination of allergic rhinitis and asthma is also known as the united airway disease, because it has been postulated that 19 to 38% of patients with allergic rhinitis has asthma, and patients with allergic rhinitis alone has very much more increased risk to develop asthma later on in their life. And being asthmatic, you have 30 to 80% chance of developing allergic rhinitis. And the severity of rhinitis truly correlates with the degree of asthma control. So as you can see in the y-axis, the ACQ score, the higher the score, the worse the asthma control. And if you can see in the s-axis, patient with no rhinitis has a low ACQ score, meaning good control. And if you have severe rhinitis, you've got a high ACQ score, which is not so good control. Other common comorbidities in asthma include chronic rhinosinusitis with or without nasal polyps, gastroesophageal reflux disease, obesity, together with obstructive sleep apnea or obesity hypoventilation syndrome, and other psychological issues like depression and anxiety. Apart from other concomitant comorbidities in asthma, all these patients are probably constantly exposed to their triggers as well. A good proportion of our patients are still actively smoking while after being diagnosed with asthma and taking our medication. Together with their occupation, occupational exposure, air pollutants, house dust mites, some medications, for example, beta blockers, aspirin, can also trigger asthma, and also respiratory infections, especially the viral respiratory infections. And let's not forget other diagnoses that come together with asthma. For example, COPD, if your patient has significant smoking history, bronchiectasis, as you can see in the CT scan at your far right, down right. And as patient ages in our population, with concomitant hypertension, diabetes, they're going to heart failure if they got ischemic heart disease, and other diagnoses which not so common like vocal cord dysfunction and tracheobronchomalacia. So Gina has actually proposed a very personalized care, and it's named as asthma management cycle. So this is the cycle that is proposed to follow every time we see an asthma patient. So the first step is to assess. So every time when we see a patient, we have to confirm the diagnosis if necessary, assess the symptom control and modifiable risk factors, their comorbidities, the inhaler techniques and the adherence, and most importantly, to explore their preference and goal in their management. So patients' training is very important in the asthma management. So patients with asthma should be educated on the disease, inhaler skills, adherence, asthma action plan, and how they can monitor their symptoms at home, especially in this COVID era. And also, we have to remind them to be compliant to regular medical review. So after assessment, we have to decide how we can further optimize the patient's symptoms and risk factors. So that includes non-pharmacological strategies like exercise, weight reduction, trigger exposure, avoidance, and so on. And then we have to adjust their medication, whether to titrate up or down, and also adjust the education and skill training based on what the patients already have. And lastly, we have to review their symptoms again, their exacerbation, side effects of their medication, their lung function, and of course, patient satisfaction towards their own symptoms and management. So to summarize, this is a diagram to illustrate how to approach a difficult to treat asthma patient. So first we have to define what is difficult to treat asthma. Is your patient truly difficult to treat, or they're actually having severe asthma? Number two is really to confirm the diagnosis, and then we can manage the other factors like adherence, comorbidities, triggers, side effects, optimize their treatment and education, do consider non-pharmacological intervention. And if all these things are being optimized, we can consider patient having severe asthma, and it's time to refer to a specialist center. It looks rather overwhelming, right? In our busy clinic with more than 100 patients waiting outside, and you have to do all this for one single patient. So this is where we introduce the nurse education program in our asthma clinic. It's been established since September last year, and we have a few asthma nurse educators trained to review patients' medication, their side effects, talk to patient regarding adherence, educating about trigger, avoidance, assess their peak flow, assess and educate on their inhaler technique, and also provide general asthma education. So in our asthma clinic, patient will first scan a QR code, which then direct them to an ACT score, and they will fill up that questionnaire to determine how well the patient's asthma is being controlled at that point of time. And if their score is 16 and above, we will send directly to doctor review. But if they score lower than that, it means that the asthma is truly not controlled, and they will see the nurse educator first. So this nurse educator will assess and manage the patients, and then only patient will proceed to doctor review with a full assessment from the nurse educator. So this will greatly help the doctor to save their time, number one, and number two, to provide a more holistic treatment or approach for this patient. So this nurse education program has been going on for a while now, but because due to COVID pandemic, we are unable to go full force. Not many patients are coming to our clinic because of clinic cut down, and that also significantly affected our nurse training as well. So from September to April this year, 219 patients actually had the QR code scanned and ACT scores filled up. And out of that, 57 patients have uncontrolled asthma. So 5 are excluded because they come to our clinic because of COPD. And out of this, 25% is actually in step 4 treatment, and the other 75% are in step 5. Unfortunately, only 14 of these patients are recruited into our nurse education program because due to lack of manpower. And out of these 14 patients, 4 patients are in step 4 treatment and 10 patients are in step 5. This is a very busy looking table, but I just want to illustrate how our nurse educator program managed to identify lots of risk factors and comorbidities in this patient that lead to poor controlled asthma. So as you can see on the third column, a lot of our patients have other comorbidities. And the next column, a significant amount of patients had a higher BMI. And a lot of patients are having poor adherence and poor inhaler technique. So after fixing all these other factors, actually less than half of them truly have severe asthma. And in fact, some of them with severe asthma have problem with obesity as well. So to conclude, severe asthma, the true severe refractory asthma, is not that common. Most of them are just difficult to treat asthma with a lot of other common contributing factors which can be managed well by us. To manage difficult to treat asthma patients, need multidisciplinary team management. For For example, if someone with allergic rhinitis, we need our ENT colleague to come into picture. And also, if they have other concomitant diagnoses like heart failure, we need our cardiology colleagues as well. And how our nurse educator plays an important role in helping us to tease out whether these are just difficult to treat asthma or they're severe asthma, and to help these patients to make their control better. And at the end of the day, asthma treatment is a personalized treatment because every patient comes in with a different spectrum and different factors that lead to uncontrolled asthma. So this is the end of my presentation. Thank you very much for listening, and I welcome questions from all.
Thank you, Dr. Loh, for the good presentation and illustrating clearly on what is difficult to treat asthma and also the challenges in managing this group of patients. There's so many factors that actually affecting the asthma control, particularly on the adherence, the inhaler techniques, which is very important and usually neglected in our day-to-day clinical practice. There's also multiple devices in the market that actually makes this condition even more complicated. So we only have another 5 minutes. So there are a few questions over here. Probably Dr. Loh, can you try to answer these questions from the audience? Are the severe asthma or difficult to treat asthma now faring worse with COVID-19 pandemic? Or in other words, are they more vulnerable than the average asthmatic patients to get the virus infection?
As far as I know, being asthma does not increase your risk of getting COVID-19 infection. However, if an asthmatic patient is infected with COVID-19 virus, they have a higher risk of exacerbation, and they will probably do a little worse compared to their control counterpart.
Yeah. So the next question would be, how many nurse educators do you have per clinic session? Because this is quite a new service that we're providing for our patients. And are there any nurses? Are those nurses are from your clinic pool nurses or the separate pool of nurses?
Okay, thank you for the question. So far, I have 4 asthma nurse in my clinic. They are actually the same nurse which is running clinic Perubatan 1 and Perubatan 3, our own nurses. So far, we only managed to run 1 training workshop since the establishment of our program. Because of the COVID pandemic, we are unable to conduct more workshops because this is a very hands-on skills, communicating with patients, demonstrating and educate inhaler techniques. So our workshop really needs face-to-face and a very interactive kind of environment. So far, we are only able to train 4 nurses. And of course, these 4 nurses still need to undergo practical training as well after their theory workshop training. And so far, we will allocate 1 nurse per clinic session. This is probably the best we can offer because our clinic also lack of nurses in general due to a lot of nurses going away, and we are unable to get new nurses because of this COVID pandemic. The new batch of nurses unable to graduate, and they are unable to come into a hospital for service. So huge lack of manpower issues. Yep.
Yeah, definitely understand the challenges of managing the difficult to treat asthma clinic. Well, do you see any other challenges that can affect the flow or the run of that clinic itself? Dr. Loh?
Yeah, I would say manpower is the first thing. We need to train more nurses. We need them to expose to more patients for better training. Other challenges would be patients' cooperation as well. Sometimes I understand the frustration scanning so many QR codes from from stepping into PPOM until coming into our clinic, filling up so many questionnaires. And some patients do have the mentality that doctor fix it all. Why am I seeing a nurse and not a doctor? But I think a lot of education we need to provide to this patient that, hey, our nurses are probably equally good, or if not better, at providing asthma education. And I think, personally, I do think that nurses are closer to patients. Like patients are more likely to open up to nurses when it comes to talking about their symptoms, about their compliance, rather than to the doctors. So yeah, I think these are the two main roadblocks so far I met when I was running this clinic. Yep.
Yes. Thank you, Dr. Loh. Because of the time constraint, we would like to answer all the questions. Probably Dr. Loh later will answer your questions personally.
Sure.
So I will end this second session of the Breakfast at UMHealth, episode 22. Thank you for joining, and goodbye.
Thank you, everyone. Goodbye and take care.